All right, we shall begin then. Ms. Reed, this is Ayman Fadl. I am the chair of the platform committee of the Georgia Green Party. Thank you very much for agreeing to testify at this hearing. We understand that you're going to make an opening statement. Is that correct? Okay. How long you want to be? Okay. And then we'll open the floor to questions. We're going to try to rotate the questions so that people will have an opportunity, and we give preference to state committee members of our party, then party members, then Georgia residents, and then anybody else who's on the call. All right. And please try to obviously with the answers to the questions, try to address them and so we can get to as many questions as possible. All right. With that, what with the hearing today is a discussion of a proposal, what we're in our numbering system of amendment proposals is HR 02, which is a measure to eliminate from the Georgia Green Party's platform certain language in both in the human rights chapter, in the introductory language, and a plank. The title of the amendment proposal was remove endorsement of Declaration on Women's Sex-Based Rights. The witness today is Miss Jamie Reed. Are you still in St. Louis, Missouri? Am I right on that? Okay. And
Correct.
actually, I don't have a great I don't have an actually introduction information for you. So if you would kindly introduce yourself.
Sure.
And with that, please begin. Thank you.
Thank you so much for having me today. My name is Jamie Reed. I hold a bachelor's degree in cultural anthropology and a master's degree in clinical research management. I worked in a pediatric transgender center in St. Louis, Missouri at the Washington University School of Medicine for approximately 4.5 years. Previous to that position, I worked as a case manager in youth HIV care. I've worked in a Planned Parenthood, and I've worked many roles that are akin to that of a social worker. I am a gay woman. I'm married to an adult who medically transitioned. I'm married to a trans man. And what I found in my tenure at the Pediatric Transgender Center was enough for me to finally leave and to submit an affidavit and file as a whistleblower with the Missouri Attorney General. The affidavit that I filed then had a written first-person narrative that was published in the Free Press. That article essentially went viral, and it led to my state, the state of Missouri, moving forward with a 4-year moratorium with a grandfather clause to stop pediatric medical transitions in the state of Missouri. I also consider myself a lifelong Democrat, quite liberal, was an anarchist in college, actually was quite familiar with the Green Party when I was in college, and have really considered myself in a very nuanced position on this issue, but has found that this issue of pediatric gender medicine has become very contentious and needs a lot of patience and time for us to explore the real tragedies of what's going on for this medical care for kids in the US.
Thank you for that opening statement. So where the floor is now open for the first question. Who wants to begin? Okay, well then I will propose a question for Ms. Reed. All right, so in the February 9th, 2023 article at the Free Press, you didn't speculate on the motives behind the center's physician co-director's actions. And in my conversation with party members supportive of restrictions on gender medicine, they have suggested that providers have a financial incentive to create, quote, lifelong patients, end quote. Do you think financial incentives have led practitioners to place people in these therapies who shouldn't be in them? And if so, would you explain how those incentives work and their magnitude? Thank you.
Thank you for the question. It's a little complex. I do believe that there are financial incentives for any field of medicine when an individual's job and career is based on that field of medicine being able to continue to operate. So once this field of medicine became rooted within the US and many of these clinicians started these practices, it did become part of the financial structure and incentive that centers like these were not closed. One of the things that I have seen in a number of these centers is that they are being operated by younger, newer physicians. So these are physicians who are staking their careers and livelihoods on these centers being able to continue. In terms of the financial structures for pediatric gender medicine, in gender medicine, the highest paid in terms of reimbursements is in a tiered structure. The highest paid is surgery. The second highest paid is puberty blockade. And the third highest paid is cross-sex hormones. The goal of almost all gender medicine is this march towards surgical procedures. So many of these centers see that their highest growth and income comes from the surgeries. But yes, you are seeing an industry that is telling patients that once they start hormones, they have to continue these hormones for their lifetime, which does create a structure of lifetime patients. One of the challenges that we see in even adult gender medicine is that there has been very little conversation or research around patients being able to slowly titrate off of these treatments once they have had enough of the irreversible changes. These treatments do have a long lasting impact on the body and are, quite frankly, they cause medical problems just being on them themselves. The financial structures to these centers, in part, is that they did have to prove to the hospitals who created them that they were bringing in money and that they needed to be left open. There is also another incentive to these hospitals that's a little bit more challenging to suss out, but there are groups like HRC that will give rankings to hospital systems and give them either a gold or a silver. They will rank a hospital system on their LGBTQIA index score. And one of the ways to get the highest index scores from the HRC is to actually have a pediatric gender center. And so part of what's challenging for me to see as a gay person is that there has been also this industry matrix made up around rainbow flag, and the rainbow flag being part of what gives a DEI and a financial incentive to hospitals to keep these centers operating.
And HRC stands for Human Rights Campaign.
Correct.
And DEI means
Diversity, equity, and inclusion.
Okay, all right. Yeah, so please remember to try to introduce the acronyms, just because, especially if you get into some medical ones that we may not be familiar with. All right. Thank you very much. Does anybody have another question? Let's see. I think there was something in the chat here. Hang on. Let's see. Oh, okay. It was just welcome, Jamie. Incredible courage. You are helping to force much needed dialogue. Thank you for your willingness to join us in having this discussion. So, okay. Another question from the audience.
I have a question.
Go ahead, Hugh. Oh, sorry, go ahead.
I can't find the button to raise my hand, but I have a question. This is Kristen speaking. Can you elaborate on specific practices or procedures that you witnessed while working at the clinic that led you to become critical of gender medicalization for children?
Yeah, absolutely. So I was there for 4.5 years. There was many practices that had me increasingly concerned as the years went on. A few of the core issues with this medical care. One is the guidelines themselves are challenging and are written in ways that allow a lot of loopholes for providers. So this entire medical field was started in the Netherlands by something that's referred to as the Dutch Protocol. That protocol has been written and brought into fruition in the US with 3 different agencies: WPATH, the World Professional Association for Transgender Health, the Endocrine Society, and the American Academy of Pediatrics. Essentially, these 3 orgs all are kind of talking to each other in a loop, but they've written these guidelines that make it really haphazard and challenging for practitioners to actually have to follow any set guidelines. The example that I like to give is when you give someone a diagnosis for diabetes, especially type 2 diabetes, there is a laboratory cutoff. You either have 5.7, 5.8, 5.9 of your A1C, or you have 6. The minute you have a 6, you are diabetic. If you have 5.9 and you have 5.9 for years, you do not meet the threshold to be treated or have type 2 diabetes. In this treatment model, practitioners essentially could do whatever they wanted. And I had clinicians who did not agree on what we were even treating, how to treat it, why we were treating it, when to treat it, which patients were treated or not treated. And it got to the point where no one was ever told no. The diagnostic criteria itself is so unclear that if a child says that they are trans and wants this medication, basically speaking, it is up to the child to make their own diagnostic determination. And I never saw clinicians say no or tell them you do not meet diagnostic criteria, or that they put any sort of no's in place. So basically, you have a whole system where children are determining their own medical diagnosis and then their own treatment plans. In addition to that, we started to see an increasing number of detransitioners. So kids who are straight up telling us, you put us on these treatments, a year or 2 later, this was not the right decision. I should never have been started on this. And they now had irreversible changes to their minor bodies. So for the kids who had been identifying as trans, their voices had dropped. There was no way that we could ever bring that back. They were going to sound male and be read by society by their voices male for the rest of their lives. We saw detransitioners who had had irreversible changes to their physical body that we could not reverse. In addition to that, we saw patients who were just having more and more significant physical harms from these treatments. So some of the things that I witnessed included things like patients who had vaginal lacerations that required that they go directly to the emergency room and right into emergency surgery. This is because the testosterone itself was causing so much degradation to the vaginal tissues that they were finding that it was tearing easily and frequently. I also saw a 19-year-old patient who had top surgery. So the patient had had a bilateral mastectomy, both of their breasts removed. They were only 19. Within 3 months of the procedure, they contacted us again and told us, begging us, that they wanted to have their breasts put back on their body. And they felt like it was a wrong decision and that nobody should have ever allowed them to have that surgery. Those kind of situations were not only becoming more frequent, but when the nurse and I said that these should be reported to the university as adverse events, the clinicians told us no, that we were not allowed. And as we saw these things increasing, I became more concerned that maybe we should tighten up or slow down some of the patients we were putting on treatments. And yet the clinicians went in the absolute opposite direction, to the point where the nurse and I were told we were no longer allowed to use the phrase, "I have concerns about this medical care." So essentially, it was a whole treatment paradigm that almost was also removed from the normal safeguardings that were within the hospital settings, in part because the clinicians would say, this is so brand new. They wouldn't allow really any other discussion about the kind of treatment that we were given. And also, because these are so small and niched centers, there would be one endocrine provider providing this care, and the rest of the endocrinologists within that division were told, you can't ask questions about it because you're not that kind of specialist. And we don't see that happen in any other kind of medical care either. So it was considered an exceptional realm that wasn't allowed to have any sort of safeguarding concerns discussed.
Thank you.
This is Denise. I have a
Okay,
question.
hang on. I think Hugh has a question first, Denise.
Okay,
Go ahead,
Sorry about
Denise.
that.
I can be patient.
okay. Well, I was wondering, how do you respond to critics who argue that these interventions are necessary for the well-being and especially addressing the topic of suicide?
So sadly, in this patient cohort, we see suicidal ideations and suicidal concerns present across the spectrum. So pre any sort of medical intervention, post-medical intervention, post-surgical procedures, we see that this is a patient population that does have slightly higher elevations of suicidal ideations than your general normative population. However, if we compare these kids who have gender issues to other kids who have other sorts of concerns like autism or other sorts of disabilities, we see that they actually have very similar suicidal ideations to other populations that have other medical concerns. What is a real shame in the treatment of these kids is that we have pulled their care out of what we know is the best practice for suicidal ideations and suicidal attempts. So that would be holistic wraparound care, significant mental health care, the use of psychotropic medications when appropriate, a child psychiatrist, a child psychologist, and a whole care picture of the child that is not just about their gender. The problem with these centers, or even with the pediatricians, is the minute that gender gets stated, it appears that all other holistic treatment models are dropped. So we had numbers of patients who had gender distress, but also would report that they had their own concerns, or family or teachers had concerns that they had autism. But what we were not seeing is we were not seeing them being treated with the typical treatment protocols we would see for a young person with autism. So we would not be seeing them in occupational therapy or having educational therapy or having speech therapy or having the other things that it could have treated their comorbidities. Instead, it became this one-track funnel where it all became gender, 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 gender. And that really is a disservice to these kids in so many ways. And this specialization and pulling them and pigeonholing them is really letting all of these other comorbidities go without proper treatment.
Thank you.
Go ahead, Hugh.
So this hearing is on a paper that seeks to repeal language that's in our existing platform. I want to read a small piece of the provision that the final paper would repeal if adopted by the convention. It pledges our party to regulate access to gender-affirming therapies to protect Georgia children from medical experimentation, prosecuting ethical violations involved with subjecting children incapable of fully informed consent to such life-changing and irreversible procedures. In your free press article published last February 9th, you wrote that some critics described the kind of treatment offered at places like the Transgender Center where I worked as a kind of national experiment, but that's wrong. So it seems that you disagree to some extent about our platform's assessment that gender medicine for pediatric patients is experimental. Can you elaborate on?
Yes, so I actually don't disagree. So there's a difference between the word experimental and research. So
Okay,
this is absolutely experimental treatments that are being propagated on vulnerable children and vulnerable populations. So this is experimental, absolutely. How it differs from research is that, and there's a little history to this, is that this was started as a research study in the Netherlands. They wrote these up as papers. They tracked the kids not very long, but they had a research protocol that they had for these kids. There was roughly 55 kids that ended up going through their protocol. It was research. It was not the standard of care, so it was experimental. A standard of care is when something has gone through so many levels of research that the medical institution has determined this is the standard, gold standard, good care. Enough doctors across the world agree that this is the standard. What happened was in the Netherlands, they had a research protocol. It jumped to England. England tried to reproduce the findings in their research protocol and could not. But they also didn't publish their negative outcome findings. So they ran the study, they couldn't reproduce the positive outcomes, but they went ahead and said, we're going to keep trying this, essentially. How this got to the United States was that there was an endocrinologist named Dr. Norman Spack, who was working at Boston University. He was an endocrinologist. He had a team. He was interested in having this come over. He thought it had some potential. He sent over a psychologist by the name of Dr. Laura Edwards Leeper to the Netherlands. She learned the protocol. They brought it back to the United States. They started this protocol in the US at a clinic called GEMS. And instead of it being proper research, they made the leap and acted as if it was a standard of care. The reason why they were able to make this leap is because these drugs were being used in the pediatric population, but for an entirely different reason, entirely different patient cohort. I've asked Laura Edwards, how did you start doing this at GEMS and it wasn't followed by an institutional review board, an IRB? An IRB is supposed to oversee the ethical guidelines for a protocol for research. And IRB is also supposed to make sure that people are consented, that they know what they're agreeing to do. And they're supposed to make sure that vulnerable patient populations have extra levels of ethical protections. Laura essentially said she just followed along with what Norman said. It hadn't crossed her mind. She wasn't a clinical researcher. And I think in retrospect, she even probably would realize that we probably should have seen this still as proper research. Instead, it jumped into the unregulated basic marketplace that is the US for medicine. And we saw it go from literally one clinic to hundreds in a few years. So it jumped out of what is supposed to happen in research. So in your platform, when you're saying that this is an experiment on kids, it absolutely is. But it's even worse than just being an experiment because it's an experiment on kids that has somehow managed to entirely circumvent all of the ethical standards that we set up about clinical research. And we as a society honestly set those up post Nuremberg and post World War II and post what we saw happening with the Nazis. The reason why these ethical principles were even started was Nuremberg principles. Then Helsinki, we've had these international principles, and yet this treatment protocol has completely circumnavigated what was supposed to be in place. And just last little bit, what we're seeing now in England is the recognition that this is an experiment that has to be put back inside of true research ethical principles to protect these patients. And that's what they're
You're
going to be
talking
doing
here
in
about
England.
the CATS review.
Correct.
Have you read the CATS review?
Yes.
268 pages worth of.
Oh, yes. And hosted a webinar, I believe a day and a half after it dropped with, I have a counterpart whistleblower in the UK named Anna Hutchinson, Dr. Anna Hutchinson. We hosted a webinar with her and Hannah Barnes, who is the author of Time to Think, directly about the CAS review.
Time to Think being the book that the journalist wrote about 2 years ago about the scandals going on at the JIDS clinic at Tavistock.
Correct.
Thank you, Mr. Reed. Oh, Hugh, you had a follow-up?
I always have a follow-up, but if others need to be heard from first, I can be patient.
Okay, go ahead, Denise.
Okay. I wonder if as I'm a physical therapist by trade, the nomenclature of early intervention, using that term for many of the things we do in medicine, do you think that might be a piece of why some medical personnel bought into some of this, that, we were told on so many other occasions what early intervention is so very important, and it certainly is in the realm of those kids that I worked with. But do you think that's part of what made those physicians not question more and kind of buy into this? Or do you have a sense of that?
Yeah, I think you are absolutely correct. There is an element of early intervention. Even when I entered this field to begin with, part of what I hoped we were able to do is alleviate distress earlier so that these kids could have a better chance of having a normative adolescence, young adulthood, so that we could intervene quicker and again alleviate that distress. The other element to the providers who work in these centers is this is grounded in pediatrics, adolescent medicine, and mental health care. And so we know that doctors don't become pediatricians often because they want to make the most money. They go into it because they really do care about kids, they care about families, and there really is so much about this care model where, we really thought that we were doing the best thing that we could at the time. And then the other element that I see in those that work in gender clinics is that we are often LGBT ourselves. And so there is a challenge to be self-critical and to be critical about something that is so personal. And there is a leap that you have to take when you might have hired practitioners who are either trans themselves or gay themselves. Many, many gay adults experienced gender incongruence in childhood. Many of us experienced distress and pain and depression and feeling left out or feeling like we weren't accepted when we were kids. And so there's this element of us trying to help, this part of the kids that we see ourselves. But then also it becomes really challenging to question that, because on some level you're questioning your whole entire community and you're questioning this whole view that to question the medical evidence is also to suddenly become transphobic, homophobic, and against yourself. And that's really challenging for providers to do.
Hugh, your follow-up question? Or
Your affidavit to the Attorney General in Missouri recounted your experience at the St. Louis clinic, but your recommendations for a moratorium are industry-wide, not specific to a few bad apples in St. Louis. Why is it that you think that the experience in St. Louis can be generalized to address the entire industry?
Yeah, that's a great question, and one that I've tried to really think about. I do believe that there are potentially some practitioners in the US who are extremely cautious, who go extremely slowly. I have to hope that there are practitioners who recognize how significant a decision like this is. So I don't discount that there might be some practitioners who are potentially trying to follow guidelines to a T or as conservative as possible. However, my staff in my center, the staff that everyone that I worked with, we were not isolated or in a bubble. So there are a number of reasons why I feel like this was the way that practitioners work across the US. We attended as a group a number of conferences. Every conference we attended as a group, what we were talking about, how we were practicing was being mirrored back to us by other institutions, other hospitals, other providers across the country. We actually intentionally went to a conference on the East Coast, and then we went to a conference on the West Coast. We are in the middle of the Midwest. We recognize that coastal trends, things kind of slowly percolate and get into the middle of the country. So we were looking at what are these two, what are the two coasts doing? And we were definitely seeing consistencies across the board at how we were practicing, and also the cohort, the kids that were coming were so similar in all of the clinics we were in contact with. We also were working on a research study directly with Stanford. So Stanford had started a research study where they were looking at, they were calling it like acceptance processes for parents coming to accept their kids as being trans. They specifically reached out to us and asked us if we could try to do a similar study in St. Louis. And when I went through their whole protocol, looked at what they wanted us to do, there were no major red flags. We were doing things almost to a T exactly the same way, because all of these centers are basing their care model on WPATH, Endocrine Society, and AAP. So in one way, we're all kind of doing the same thing. The last piece that made me almost worried, like even more worried about the rest of the country, is that there is an internal listserv, an email listserv for gender clinicians who work in pediatric centers. This is not a WPATH listserv. This is just a listserv if you're a pediatric gender clinician. My clinicians were on that listserv, and they would read out loud to me things that were being spoken about in that listserv. And once the nurse practitioner even said to me, Jamie, I know you have concerns about how we practice here. If you looked at this listserv, you would feel like we are the most conservative and everyone else is completely reckless. There were clinicians on there that had never even heard of WPATH, that had no idea there were written guidelines at all, who had no idea that there was a DSM-5 mental health diagnosis that was supposed to be given or even looked at for these kids. There were clinicians on there in the US who were just doing whatever they wanted. And she would read some of those out loud, which makes me think nationally, we have a major problem with this care model in this country.
Thank you. Carol, and please forgive, I don't know how to pronounce your last name, so Bolden, I hope. You have your hand raised? Carol, you have the floor. Okay, we'll get back to Carol in just a second.
She's unmuted.
Okay, go ahead.
Sorry, I had to unmute. Yes, Jamie, thank you so much for coming today, speaking to us. I wanted to ask you, I missed the first couple of minutes because I couldn't couldn't get the link to work. Would you please go over again the very beginning of what you were saying about how this got started, and particularly how the U.S. got so entrenched.
Yeah. So once it got to the US, it started off in the GEMS clinic in Boston. There's this other historical element that sometimes most people don't even realize. So at WashU School of Medicine, where I worked, there was actually a gender center in the 1970s that was operating there. This is almost the second time we've seen a wave like this come across the US regarding gender medicine. The first wave happened in the early 70s, and we actually saw most of those clinics open. They started to have poor outcomes, and most of them were closed in the next couple of years. So there was a clinic here in the US, opened and closed.
Was this right after Christine Jorgensen?
Yes. Yes.
Okay. Yeah.
Yeah. I mean, we see popular culture embrace some of these treatment modalities, and there's an element of this that is one of those popular culture disseminations. In the US, though, what we started seeing was that all along there was this tiny cohort of kids who had early onset, really distressing gender issues. And the cohort was tiny, like minuscule, like maybe 10, 15 kids in a whole year would present in a major metropolitan area. So it's not that I or many of us would say that this is like some completely made up condition. This condition has existed, and there's been kids with this major distress that we've seen for decades. But what would happen back then is that they would get tapped into a mental health care treatment modality, often called watchful waiting, where they would try to support the family, support the child, and sometimes we would see that move on to interventions. And there were kids that were treated very, very, very rarely in the US. But the vast majority of those kids that had that early onset distress would desist. So by the time they were going through adolescence into adulthood, they would no longer have the gender distress. I think there's a unique element in the Western world and in the US and English-speaking countries where we saw a number of clinics open. And on some level, if you build it, we can create demand. And so we built these centers, and it was not enough. It wasn't enough that the center existed. It had to be that the center existed. The journalists had to come and cover it as a media story. We created this whole wraparound cultural movement in the creation of this whole new idea about the next civil rights era was going to be about trans kids. And so it picked up a social, psychological milieu that just kind of spread. And I think on some level in the US, we're always looking, what's the next progressive thing we can do? What's the next civil rights era? What's the next thing we can move forward? And this became one of them. And it also correlated at this horrible, I don't think you could have a Venn diagram, have more overlaps. We saw this occurring at the same time we saw this huge social media change. All of the teens now have a cell phone. Cell phones are now ubiquitous. They're no longer interacting in real life. Instead, they're on TikTok, Instagram, Twitter. And then on top of it, we have the first real lockdown for a pandemic that many of us have ever experienced in our lives. And all of a sudden, our kids aren't at school. And so some things were created for this teeny tiny cohort. And instead, we were flooded with this whole new group. And we did not have the wherewithal to pause or take a breath or say, this is a different group. We need to rethink what we're doing.
Yeah, it also correlates with the expansion of corporate run for-profit healthcare.
Oh, yes.
Yeah, which I think is really pivotal because we've had this whole shift in the medical community, well, in the entire country, where everything's about the profit motive. And, we had that failed attempt to try to get some kind of Medicare for all. Well, we're still trying to work on it. We're actually trying to work on it here in California. But the attempts to try to do that in the 90s that the Clintons made, foundered. And then, and then we saw this whole expansion of the, everything being about the stock market. And that's one of the things that happened with another part of the perfect storm is, the technology, as you were mentioning. But, all these things kind of coalesced into making this really become an issue. It's been in Forbes magazine as the next new, thing to invest in that's going to really pay off for investors,
Wow.
I'm sure you're aware of that.
All right. Thank you, Carol. Thank you, Ms. Reed. Hugh, I know you have a question. I'm going to take this opportunity to ask a question of my own before you get your next question in. All right, Hugh?
All right.
Okay. So, Ms. Reed, in USA medicine, we have licensing boards and malpractice lawsuits. And this is the way, in theory, that the medical profession disciplines substandard practitioners, right? And obviously third-party payers, such as private insurance programs, Medicare, Medicaid, VA, Veterans Administration, also influence what practitioners can do and not do by their financial incentives. And then some states will impose additional regulations specific to specific areas of medical practice. So the current version of our platform includes the following. We will regulate access to gender-affirming therapies to protect Georgia children from medical experimentation. I think Hugh referred to this earlier. What regulatory measures do you believe would be reasonable to ensure that gender-affirming and I know you already answered the question that you want a moratorium, but assuming that in the jurisdictions where there hasn't been a moratorium in place, what regulatory measures could be enacted that would ensure that gender-affirming therapies are provided in an ethical manner or a more ethical manner?
Sure. So I think my baseline would be we need a moratorium for minors until we can clearly indicate if there is any research to suggest that these treatments are helpful. If that is not the case, and we're looking at purely regulatory elements, I think that there would need to be clear assessment protocols written, the number or length of time that mental health treatment would have to be provided before any medical interventions would have to be not only spelled out, but have to be documented in a medical chart. So for instance, if you had a young person who has experienced gender distress before any protocols would ever be considered, you'd have to be able to demonstrate they've had psychotherapy for this many numbers of years. This psychotherapy has improved or has not improved. If the patient is still insistent, consistent, persistent, and then elements around age for treatment guidelines. So one of the things that England is recommending is that probably 16 would be the treatment cutoff or start date for cross-sex hormones. So hormones such as testosterone or estrogen or spironolactone or some of the other feminizing hormones. So I think if you're going to have regulations, those need to be not only evidence-based, but then clearly stated, and then have mechanisms in place that if providers were not following those regulations, then yes, what you're talking about would jump in. The current guidelines are written to say cross-sex hormones should start at 16. And then they give these little caveats to the docs, unless you feel like there's a pertinent reason why you want to start this at any younger age. Which is why in my center, we started at 16. The next thing you knew, we're at 15. Then we're at 14, to the point where we are routinely prescribing testosterone to 13-year-olds. So guidelines or regulations or things like that need to be clear, specific, and really be based on evidence. And I think the systematic reviews of evidence right now show that there is no evidence supporting the use of puberty blockade at all, that there's more harms than benefits in pubertal blockade. Cross-sex hormones, potentially with start at the age of 16 after really tight regulations about the use of psychotherapy before they're ever prescribed. And then also regulations around vulnerable populations. So even a 19 or 20-year-old who has diagnoses of developmental disabilities or autism disorder or really struggling in other aspects of their lives, there should be guidelines that they are also not just prescribed testosterone after a 30-minute visit at a Planned Parenthood.
Thank you. Go ahead, Hugh.
You keep coming back to this idea of evidence-based. You have suggested that while the Dutch protocol may have started out looking at the evidence, that its adaptation in the UK and in the United States ignored their diagnostic criteria. Am I understanding this correctly?
Correct. They had
Yeah.
much stricter diagnostic criteria that did not come over to the US.
So in the original study of the Dutch protocol cohort, we didn't see these comorbidities.
Correct. They were intentionally screening out patients with significant comorbidities.
And so the only issue at play in that small cohort was their gender confusion or what have you.
Correct. Their gender incongruence, but also they had to have full family support.
Okay.
And they had to have well-established early onset gender incongruence from an early age.
Now most of the people being treated, most of the pediatric patients being treated in gender clinics are what we call rapid onset or late onset. Not late onset, but rapid onset.
They are 16-year-old natal girls. That's the most common presenting age in my pediatric gender center was a 16-year-old girl.
Who 2 years ago showed no evidence of.
Correct.
So none of that persistent, consistent, insistent, whatever that phrase is.
Right. And they also had significant comorbidities. They were showing some pretty high need mental health issues, autism, borderline personality disorder, significant eating disorders, self-harming behaviors, suicidal ideations. They also had a higher rate of trauma histories, sexual abuse histories. They were in foster care or they had some sort of traumatic family history. And they also didn't have family support. So they would be from divorced homes where one parent would say, I've never seen a single element of gender in this kid at all. I'm not going along with this. They did not meet the Dutch protocol guideline at all on any of the three core elements.
So when we talk about evidence base, for the layman who's not a medical researcher, what are we talking about here?
So, evidence itself basically just means you don't want to utilize a treatment. I think it goes back to the understanding that changing or putting anything in the body of a healthy human being has a risk of side effects. So you want to have strong proof that what you're going to give has more possibility of providing benefit than harm. The benefit has to outweigh the potential for harm if you change the body at all. And that should be simply that should be all of what we look at. I often think about Rachel Carson and the book Silent Spring. So when I think about how groundbreaking that book was, her essential argument is we should not be putting anything into the natural environment until we can first prove that it's going to be beneficial to the natural environment and not cause any harm. And that same exact standard should hold across what we do for medicine. And I know that adults have the right to make decisions about causing harm to their own bodies, but we should, as a society, have that exact same principle for kids. We should not ever put anything into a child's body until we can first prove that it has true benevolence, that it's beneficial, that it's not going to cause harm, as opposed to we give it to you and then we find out 20 years later, oh, sorry, it was a carcinogenic and we just killed all the songbirds. Like that was her argument. And that's kind of how I see this medicine happening also.
So you're urging a precautionary principle here.
Yes.
Okay.
Ms. Reed, I have a question for you, seeing nobody else has their hand up. All right, so in your article at the Free Press, you discussed negative outcomes for minors. And do adults undergoing these therapies achieve better outcomes? And if so, is it because they have fewer comorbidities? Is it because of their self-diagnoses are more accurate, so they tend to be the patients for whom the therapy is more appropriate? Can you talk a little bit about why? I guess what I'm trying to say is, if the therapies are harmful for minors and they should be the moratorium on the therapies for minors, shouldn't there be similar? Should there be similar moratorium on adults? Just like we didn't allow, most states didn't allow Kevorkian to go around and, and and do his thing just because somebody consented to it, right? That's, so.
Right. I think for adults, you get into the concept that adults should have some more right or ability to make decisions for their own bodies, even knowing that there will be inevitable harms. So we still live in a society where we agree to some regulations on tobacco products or alcohol, but we recognize that adults are going to do things and utilize things that could potentially have significant risk of harms. Most trans adults recognize the trade-off that they are going to be trading off some elements of their long-term health for these treatments. And what used to be better care given to adults, we slid this into kids, but we also started giving adults worse care. So what used to be better care for adults is that they also went through steps of psychotherapy, worked with a psychotherapist in a therapeutic setting where they actually were given much longer time to weigh out the risk benefits for their own decision making. And what we've done is we've basically said, we're going to move this into kids. And in doing that, we also took away all of what was called gatekeeping from adults. In some ways, there's, those are questions as a society. How much gatekeeping or safekeeping do you want to do with adults? How much independence or ability for adults to harm their own body do you want to give them? Those are societal questions that we can ask. I think where it comes to children, you're dealing with a vulnerable population that we've already as a society have made some basic agreements on. We do not sell alcohol to minors. We don't sell tobacco to minors. We also don't routinely allow minors to get tattooed. Certain elements like that. But adults used to also have better care too. They had better wraparound care. I know a number of trans men who have gone to Planned Parenthood for their hormone care, and they're being treated with a substandard care protocol. So originally, when we would start adults on testosterone, we knew that we needed to check their hemoglobin, hematocrit, their cholesterol, their lipid panel, because we knew these drugs were going to affect those things. Now, Planned Parenthood is putting kids on these treatments, and they're not even doing baseline proper diagnostics. In essence, I feel like my community is so vulnerable that we are being taken advantage of by these institutions. It's the gay, the queer, it's the different kind of people that get this terrible care. And that's kind of what's being propagated on even adults with gender issues.
Thank you. Next question does anybody have I have a couple more questions, but is that Hugh? Go ahead, Hugh.
So, as I understand it, you've got 4 or 5 kids yourself?
I have 5 boys.
5 boys. I don't envy you. But I'm curious to know what impact parenting children and parenting children with a partner who herself identifies as trans, how that has impacted your position that we need a moratorium and your work to expose yourself to ridicule as a whistleblower to talk about these issues.
In my process of coming to understand this medical care, as I was working there, one of the very first things I recognized was that I would never bring my own children to this clinic. And that, sorry, I just gave myself goosebumps. As a medical provider, you don't ever want to be in that position because you want to only work in a field where you want every kid to get the best care. And when I came to the realization that if my own child came to me experiencing gender distress and that I would never take them here, that was a huge warning to me that we were doing something ethically wrong. And the thing that scared me even more is that I was not the only one who worked in that center who felt the same way. Mm-hmm. In terms of my own kind of position in the LGBT, I think so much of this has come from that I've worked in some ways with my community for my entire professional life. And so I just see a vulnerable patient population that's being given poor care, and I don't want to see that happening anymore. This has been challenging in my own personal world and my own personal life, I also have a sister with a trans-identified partner, and they don't speak to me anymore. Because this is so contentious, this is so challenging to have these conversations. But what I do believe is that adults can tackle challenging things. I believe that we can figure out ways to have a dialogue about actual medical procedures and actual social policy where we recognize that everyone has baseline rights that we need to stand up for. And then we have to determine how as a society we're going to navigate these instances where some people's rights butt up against others. And what can we do to make sure that the most vulnerable's rights are always taken care of while we recognize that everyone has a line of baseline rights. So I believe that trans adults absolutely have the right to a job, a family, medical care, to be able to live in society. But I also believe that gender nonconforming people have the same thing. You should not have to medically transition. If you are a gender nonconforming human being, an adult, we should also give you all of those basic rights. There should be no pressure that you have to physically change your body. And those are huge things that we still have to change in society, but we're not going to get there if we can't even have a conversation about what medical care we're giving to children.
As someone put the question, whose bright idea was it to sterilize all the queer kids?
Ms. Rita, so I have another question for you. Do you have, I mean, I'm not sure even, and this, if feel free to say, I don't want to talk about this as it's not in my area of expertise or what I've been thinking about, but do you have any comments on other aspects of the Declaration on Women's Sex-Based Rights?
Yes. Even in the Gender Center, we were having conversations about sports and the ability to protect the sex category of women's sports. I absolutely believe that there is the need for a sex category for women to participate in sports that's protected. But I also believe that we should be opening up the other categories so that gender diverse or trans-identified women feel not only welcome, but accepted to work and be and enjoy sports in those categories. And then also there are clearly identified elements in our society where we have to look at the baseline rights of women. And that is the right to safe spaces. That is the right to sex spaces in terms of domestic violence, in terms of even, I mean, honestly, even lesbian dating apps. Like there has to be the ability for some basic rights of all categories to be respected. And that does mean that we have to recognize that there is a sex-based category for women that deserves the right to basic dignity.
Thank you. Any further question? I have one more question, but if does anybody have another question that before? Go ahead,
Kristen
Kristen.
speaking. Ms. Reed, I don't, you may have covered this, and if you have, please forgive me, but what alternative approaches do you believe should be taken for children with gender dysphoria without resorting to medical interventions?
Great question. The first thing is the American Academy of Pediatrics actually needs to go back to their pediatrician base and teach them how to explain to families that gender questioning and gender curiosity is a normative part of human development and does not need to be pathologized in any way and does not need any sort of medical intervention. So that means that pediatricians needs to step up and say, if your child wants to paint their nails, they can paint their nails. We let them explore. We do not have to pigeonhole any kid's exploration in any way. What has been falling short is the minute gender is brought up in a pediatrician's room, they get referred to a specialty gender center. Those specialty gender centers are medical pathways. Pediatricians need to get into this and they need to start talking to parents about ways to talk to their gender exploring or gender incongruent kids. Then The gender incongruent kids who also have distress from that need to be given the same first line treatments that we give other kids with mental distress. They need wraparound holistic care. That could be psychotherapy if needed. It could be psychotropic medications if they reach that element, but also we have another problem right now where we are pathologizing most normative distress in kids. You cannot become a strong human being if you do not develop resilience. And the only way to develop resilience is actually have to deal with the fact that things go wrong. And so in my own kids, we have to teach ways to push through resilience. And those strategies have to be internalized, and they have to learn ways to deal with the world in real life. And so I know we go psychotherapy, psychopharmaceuticals, like, but we do have a problem right now also where we are not creating resilient kids who can problem solve on their own, kids who go play in the woods and fall down and like tear up on their knee and have to figure out how they're going to get their brother home. Like, these are the things that kids need to experience and deal with. Yeah, it's messy and can be upsetting, but that's how we build resilient children. And I believe that gender incongruent kids have just the same capacity for resilience as the rest of us.
Thank you. I agree.
Ms. Reed, in your discussion of the minors receiving care at the clinic at which you worked, I was curious, where are the guardians and in the consent process, I guess, of how this works? I mean, so are they is there consent given, but you believe that the consent was obtained fraudulently or in a misleading manner, or is it, there was no consent process at all with the guardians? Thank you.
Great, good question. So I had one prescribing doctor who every visit would say to the parents, you can either have a dead daughter or living son. So she was utilizing tactics with parents that were not part of a true informed consent process. In fact, they borderline on bullying, and they were coercive. That provider had a trans-identified child of her own that she had medically transitioned as a child, and she very much had this, you have to do this, this is the only way forward. We also had cases where I would see, I was in the room a lot when these conversations were happening, where I would see parents really struggling, and they would turn to their kid and they would say, are you sure? This is your decision, or I have questions, but you're telling me this is what you have to have. And that's really hard for kids because we were shouldering them with the responsibility of making the decision that the doctor should have been making. My own center also did have some really poor practices. We were not utilizing an informed written consent process. So if I go to take my kids, if I go to the hospital for my kids to have their tonsils removed, I'd have to sign a very specific written document for that. We did not have any written documents for these treatment protocols, in part because the endocrinologists on my team felt like it would be a barrier to care if we had parents sign something, because they would be less likely to sign it and put in writing what they were actually consenting to. That's not right. And then the other element that I struggled with dearly was divorced parents who shared joint custody of their children. And we would bully and misalign the parent who was not in agreement with a medical pathway. And oftentimes the parent who was not in agreement with a medical pathway simply wanted their child to have more time. They were asking, can we do 6 more months of therapy? Can we do a different kind of therapy? We also add this kind of treatment in? And we really bullied those parents. we were making fun of those parents in our own team meetings. We were acting like they were stupid when they're just asking more questions and trying to be more thoughtful about their own kids' physical bodies and their lives.
Thank you. Any other question? Go ahead, Hugh.
You've mentioned systematic reviews on a couple of occasions and made a couple of references to the CAS review, the final report that came out a couple weeks ago. Can you tell us what is a systematic review? What is its significance in the consideration of the evidence base for a treatment protocol? Have there been other systematic reviews other than the CAS report? And now that we are starting to read these systematic reviews, what do you think is required of us going forward?
I believe in total, I think there's been 7 systematic reviews of evidence completed internationally for this medical field. None of them showed all of them basically showed there's low quality evidence or low evidence for the support of these interventions moving forward. Systematic reviews of evidence are considered the very top tier for a medical care. It's considered, the highest level of the pyramid. There are critics of this that basically say that there's no way to do a randomized control trial of this kind of medical care. So a randomized controlled trial, especially if it's double blinded, is the doctor and the patient don't know if they're actually getting the medicine or not. You can do that in medicines that don't cause a lot of outward changes. The critics, can rightfully agree to that. But at the same time, you can do much better research than we've ever seen come out of this care model. So the Dutch protocol, when they started it, they wrote a protocol that in order to get the data from the back end, you actually had to go to surgery. They wrote it, in essence, to only capture those who were happy, because those were the patients that were moving on to the surgical procedure. If you did not move on to surgery, you were not captured in their data set. So the longitudinal way to create these studies should have been, we're going to track everybody from the minute we give an intervention and longitudinally as long as we can possibly go, because it is not enough to find a study that only tracked for 1 or 2 years. And that was a lot of what Dr. Cass was finding, is that so many of these studies are short-term, 1 to 2 year studies, and that does not capture the whole life course of an individual who is undergoing a treatment that will radically shift their entire life. This is your trajectory in life, your gender outward presentation. This is about future partners and fertility and sexual function and how you operate in the world. And these studies were just not built in a way to capture good, solid evidence. And so that's what, in part, what these systematic reviews of evidence are telling us. We don't have any good research. We definitely don't have any really good research on the kids. And therefore, if you don't have evidence of positive benefit or outcome, you should be relying on a cautionary principle and not moving forward with these treatments.
Does anybody want to ask another question of Ms. Reed? Well, I'm going once, going twice. Ms.
Yeah. So your clinic in St. Louis was starting people on cross-sex hormones as early as 14 and 15. Do I
13.
understand that correctly? 13 years old.
13.
And I assume y'all followed the Tanner phase 2
Correct.
on the puberty blockers.
Yes.
And so what was the youngest Tanner phase 2 patient that you put on puberty blockers?
Definitely 9, maybe 8.
Okay. These puberty blockers have adverse impacts on fertility, do they not?
Yes, especially in the boys.
These kids at Tanner stage 2 who are 8 and 9 and 10 and 12 years old, do you believe that they're capable of giving consent to the loss of fertility when they haven't had their first kiss yet?
No, it's not only that they were having to consent about this abstract concept that they did not even have the ability to comprehend, but there's an element to a pubertal blockade in a Tanner stage 2 boy that you'd also have to be consenting to the agreement that your body would never physically develop. It's challenging to even really think through how to explain this, but we were intentionally putting a child on something in which their genital organs would literally not grow. I mean, we are keeping you stunted in a childhood development. And these are things that I don't think they fully could even understand what these next steps would be. You know, explaining to a child that age what sperm is, or a testicle is, or penile growth, or what this means for your long-term ability to have any sexual function is really, you know, those would have been we didn't have those conversations. The conversation around fertility would literally be about 2 sentences. Do you think you want to have any biological children? Yes or no? If yes,
Of a 10-year-old.
yes. Do you think you want to have biological children? I mean, as somebody who's worked in social work roles, we often talked about making sure that we were communicating at a 6th grade reading level, and that would be how to talk to adult patients. Like, that's how we were trained to talk to adults. But we were asking these questions of children. And then when the kids would say no, we often left it at that. If they would say yes, sometimes they would then turn around and say, but I'm just going to adopt. And as an adoptive parent, they had no idea what they were talking about. They viewed adoption like you go into PetSmart and you see the kitty cats in the front, and this is what adoption is. And it was like, no, they had no concept of what that would mean, or how that would change your family dynamic, or if your partner would be open to adoption, or if they wanted to have like there was no comprehension to what they were truly consenting for at all.
All right, so Carol has her hand up.
If I may, just one real quick follow-up. Do you think that it's possible for parents to consent on behalf of their children to such interventions?
There's actually been some questions on the legality of that. There have been questions if it's even legal for a parent to sterilize their own child. And so I don't know that. I think we've entered into a realm too where there's questionability about even if a parent even has the right to make that consenting decision for their own child.
Thank you.
Carol, go ahead, please.
Yeah, I was just wondering about the guy that started this here in the U.S. He was an endocrinologist. Was it Dr. Norman Spack? Was that
Yes.
his name?
Yes.
Okay, because All right, and then the Dr. Laura.
Edwards Leeper.
Okay, and she was a psychologist.
Yes.
Or is,
Yes, she still is. Yes.
and they're both located in Boston.
Laura now lives in, well, I think it was Oregon. She was actually just on NPR 2 days ago talking about the CAS report.
Oh, is that right?
Yes.
Criticizing it?
No, actually, no. Laura Edwards Leeper actually became probably one of the first known whistleblowers in the US. She
Oh,
wrote
really?
an op-ed that was published in the Washington Post with a trans woman named Dr. Erica Anderson. They co-wrote an op-ed piece basically saying that pediatric gender care in the US has gone completely off the rails and that kids were being harmed.
Oh, wow. And where was that published?
I think it was the Washington Post.
That mostly sounds.
If there's, pardon me, I was gonna say, we do record and publish these videos on YouTube. If you have some like links or other items that you want us to include, we can probably put it in the YouTube video description, right, Hugh? That'd be something we could do.
Sure. Sure.
Yeah,
Absolutely.
and I just pulled it up. It was the Washington Post, and the story is called "The Mental Health Establishment is Failing Trans Kids."
And when was that published?
November of 2021.
Okay, thank you.
Wow, that's quite a while ago. So, yeah, like you say, she was one of the first whistleblowers then.
I do have another question for you, Miss Reed. Now we were talking about parental consent. What happened at your clinic with regards to children who, for lack of a better term, just because I don't know the legal term, were wards of the state? So maybe they were in, juvenile detention,
Foster care.
or and I'm not sure what the status of foster parents is in terms of medical consent. Can you talk about those kinds of situations and how consent operated in your clinic?
Yeah, we actually border two different states, so Illinois and Missouri. So my center was pulling in patients from both sides. The two different states almost had totally different opinions on kids who were in state custody in foster care. Basically, in the state of Missouri, if you were in foster care, you probably were not going to be moving forward with a medical transition. The caseworkers who are the representative of the state as your legal guardian were not given the real clearance to consent for these treatments. However, the state of Illinois, which has now become a sanctuary state, was basically allowing the caseworkers to provide consent on behalf of the state, and they were not deferring to parents, even if the parents' parental rights had not been terminated.
Oh, thank you very much. Okay. All right, we are approaching an 5:30. I see Hugh has another question. Do any of the other of us who haven't asked as many questions as Hugh and I have, is there anybody else who wants to ask a question before Hugh might get the final question here? All right, go ahead, Hugh.
Curious to know what evidence or research supports your opposition to child gender medicine. Are there particular studies or findings that influence your perspective? Who are the researchers that you're trusting on this subject? What are the provocative papers that have made you sit up and take notice?
Interestingly enough, quite early on, it was the Endocrine Society's own written guidelines that really brought me into some pretty serious consideration. So one of the things that I was trained to do in my master's program was when we were reading guidelines or things like that is, I would get a set of colored markers and we were looking for rating scales, high quality, low quality, high quality, low quality, moderate quality.
The
So
evidence on which it was based.
correct, the evidence on which it was based. And so one of the things I did much later in my tenure is I just took the Endocrine Society's own written guideline and I went through it with that same kind of green is high quality, yellow, red. And when I did that, I remember feeling, like my stomach drop out from underneath me because they even recognized in there, this is all based on low quality evidence. And seeing that so clearly laid out was really kind of, I felt I was upset at myself for having not done that earlier, even though I was not the clinician. I still was upset that I had kind of gone along with something, when it very clearly is just saying, hey, this is very, very, very low quality. Some of the other, I actually worked on a number of studies and have a number of published papers of my own. And some of what I was finding within our own research was part of what was making me pause. So we were doing a research study with Stanford and we were doing these in-depth, it was an hour-long interview with the young person and then an hour-long interview with the parent. And we had specific coded questions. We were looking for coded phrases. We were looking to really take apart this relationship and find out what was going on. And it was my task to do the intensive interview and we recorded them. And in the process of starting to analyze this data, what we were seeing was that there were a number of patients who they themselves were talking about feeling like they were in a social contagion, that they had been caught up in a social contagion, that they were recognizing that this was not the proper pathway forward for them. And then seeing the parent talk about how rapidly this came on or how much social influence there was. So as part of it was even our own research. And then we went to do a research study with another group. And what we started to do at the very beginning was we were just trying to compare basic demographics. And I said, well, we have a 70-30 split. What do you have? And we had 70% of our patients were natal girls and 30% were natal boys. And they said, oh yeah, sometimes we hover around 80-20. And we were all talking about this in a research level. And there was no pause. Why the hell is this cohort completely reversed sex-based presentation?
Somewhere, what, 10 years ago? Yeah.
And how did that happen? And why did that happen? And so part of it is just like all of these research questions are just swirling, but the fact that all of these other researchers were just like, oh yeah, that's what we see. And it was like, wait, this is the problem itself. Like, this is the research question. Why are we seeing this? Not like, how do we get the parents to accept their trans kids faster? It was our own demographic base was the research issue itself. Honestly, then the CAS report to me was, I felt a lot of peace after reading it. The things that I was seeing for years were just being, they just flowed with what this very prestigious pediatrician found after 4 years of research. And that just felt, that we're on the right track and trying to figure out what's gone so wrong and how to claw ourselves back.
And just to clarify something you just made reference to, the CAS team did original clinical research. They formulated research questions that had not been answered by prior research, and they commissioned studies.
Right, and they did a lot of quantitative, but also qualitative. They did qualitative interviewing, and they met with families, and they met with trans kids, and they met with parents, and they really took their time to listen to the young people too.
And it sounds like your joint research project with Stanford also pretty much validated what Dr. Littman has been finding about social contagion,
Yes.
about the role of social media, about the girls self-diagnosing as a community,
Yes.
all of that.
Yes.
Okay, well, Jamie, I'm sorry, Miss Reed, do you have any final word that you'd like to the audience to hear from you before we close the hearing? I want to thank.
You have a very well-educated group. You asked very good questions and clearly are really thinking about this topic, and that's what we need for our society right now. So thank you for being so well educated on this.
No, we thank you for spending your time. And if you like to watch us, look for our channel where we publish this testimony on YouTube, and you can obviously share it in your circles.
Perfect.
And with that, I just want to encourage those of you who are in Georgia to register for our May 18th additional nominating convention. Our website is georgiagreenparty.org. And that will be the next major event on our calendar, georgiagreenparty.org. All right, thank you so much. Have a good
Thank you
day.
so much, Jamie.
Thank
Stay
you.
well.
Thank you
Thank
for
you.
being with
Enjoy
us.
those boys.
Yeah, you're doing great work.